محمد.
السلام عليكم، تسمعوني؟ واضح الصوت؟
نعم واضح.
طيب السلام عليكم. My name is Dr. Mohammed Al-Mutlaq, R1 King Khalid University Hospital. Today, inshallah, I will talk about arterial septal defect. Introduction. Arterial septal defect is the form of congenital heart defect that enables the blood flow between the left.
محمد لو سمحت تكبر السلايدات.
Inshallah, sure. That blood flow between the left and right arteria via intra-arterial septum, depending on the size of the defect, the size of the shunt, and associated anomalies. This can result in the spectrum of the disease from no significant cardiac sequel to the right side volume overload, pulmonary arterial hypertension, and even arterial arrhythmia. The three major types of arterial septal defect account for 10% of the all congenital heart disease, and as much as 20 to 40 of congenital heart disease present in the adulthood. More than 60% of the healthy full-term infant have patent foramen ovale. Patent foramen ovale is present in the 1/3 of the people under 29 years old of the age, 1/4 of those 30 to 79, and 1/5 of person older than 80. Secondum, arterial septal defect occur in the 10 to 15% of the congenital heart defect in children, and 20 to 40 defect discovered in the adult. Women are affected twice as often as men. A significant number of arterial septal defect close spontaneously within the first few years of the life, but spontaneous closure after age 3 to 4 is rare. Natural history. Although the life expectancy is normal for the patient with arterial septal defect, patients generally survive into adulthood without surgical or percutaneous intervention, and many of the patients live to the advanced age. Natural survival beyond the age 40 to 50 years is less than 50%. Advanced pulmonary hypertension symptoms occur before the third decade. Late complications are stroke and arterial fibrillation. And the embryogenic, the partitioning of the arterium beginning with the appearance of the septum primum at about 28 days. The crest, this is the crest of the tissue that growing from the dorsal wall of the arterium toward the endocardial cushion. The ostium formed by the three edges of the septum primum is the ostium primum. Before the septum primum fused with the endocardial cushion, perforation appear in the upper portion of the septum primum. This the perforation will coalesce to form the ostium secundum. Unlike the septum primum, septum secundum does not fuse with the endocardial cushion. It is a three-edge form of the foramen ovale. At the end of the 7th week, the human heart has reached the final stage of the development. Because the fetus does not use its lung, most of the blood is diverted to the systemic circulation. This is accomplished by the right to the left shunt of the blood that occur between the two arteria. The foramen ovale and the septum primum control this right and left communication. This septum primum acts as the valve over the foramen ovale. At the birth, the child will use its lung for the first time, and consequently, more of the blood will flow into the pulmonary circulation. This pressure increase in the left atrium, where the pulmonary vein empty will force the septum primum to push up against septum secundum. Shortly thereafter, the two septa fuse to form common arterial septum. Type of arterial septal abnormalities. Patent foramen ovale, failure of the septum primum and septum secundum to fuse. A failure of the fusion results in either valve competence or incompetence with or without aneurysm of the septum primum competent. Septum secundum lie within the boundaries of the fossa ovalis. Widely range is morphology. In the morphology from the slight like patent foramen ovale at the superior aspect of the fossa to defect involving the part or all of the remainder of the fossa with a single or multiple fenestrated communication. form as the result under development of the septum secundum or an abnormal pattern of the septum primum resorption. Septum primum defect is the persistence of the ostium primum and is the most common associated with the arterioventricular septal defect. Sinus venous arterial defect, always associated with the partial anomalies, pulmonary venous connection. The more common superior variant is the intra-arterial communication, lying posterior and superior to the true arterial septum, and the superior vena cava overriding the defect. The right upper pulmonary vein, usually two or more, drain to the right atrium at the superior cavo-arterial junction, or enter the superior vena cava directly. The less common inferior sinus venous defect is the communication inferior and posterior to the fossa ovalis, with the right pulmonary vein entering the right atrium near to the inferior cavo-arterial junction. Patent foramen oval or secundum arterial septal defect may be be present. This is the picture. Mixed arterial defect. The inter-arterial septum can be divided into 5 septal zones. If defect involving 2 or more of 5 septal zones, this defect is termed mixed arterial septal defect. Genetics. Arterial septal defect may occur on the familial basis, like Holt-Oram syndrome, characterized by autosomal dominant pattern, inherit, and deformity of the upper limb has been attributed to the single gene defect in the Qbqs. The penetrance is nearly 100% for Holt-Oram syndrome. Approximately 40 of Holt-Oram syndrome cases are due to new mutation. Ellis-Van syndrome is autosomal recessive. ايوه هنا ايوه خلاص يعطيك العافيه. In the newborn and infant, pulmonary resistance is high. Left and right ventricular compliance are similar, and the net shunt through the ASD is typically slight. The magnitude of the left to the right shunt across the ASD depend on the detected size, the relative compliance of the ventricle, and the relative resistance in the both pulmonary and systemic circulation. As the left ventricle mature postnatally, it becomes thicker and less compliant in the diastolic than the right, and account for the high left atrial pressure than right. Shunting across the intra-arterial septum is usually left to the right and occur predominantly in the late ventricular systole and early diastole. A transient and a small right to the left shunt can occur especially during the respiratory period of decreasing intrathoracic pressure, even in the absence of pulmonary arterial hypertension. The functional loss in the left and right ventricle is normalized 6 months followed ASD closure in the child and young adult. Pulmonary hypertension associated with the isolated ASD is rare in children, although 35 to 50 of the patient with unrepaired ASD. One third demonstrate an elevation BVR before 20 years of the age, one third between 20 to 40, and remainder after 40 years of the age have elevated pulmonary resistance by the age 40. The chronic significant left to the right shunt can alter the pulmonary vascular resistance, leading to the pulmonary arterial hypertension, even reversal of the shunt and Scimitar Syndrome. Clinical presentation. Great majority of the ASD are asymptomatic. Common presentation symptoms including dyspnea, easy fatigability, palpitation, sustained arterial arrhythmia, syncope, and heart failure. Shortness of breath during exertion, recurrent respiratory infection, feature of pulmonary hypertension, Scimitar Syndrome, or mitral valve insufficiency, leading to the further increase in the left arterial pressure and higher degree of left to the right shunt. Several mechanisms. The first age-related decrease in the left ventricular compliance augmented the left to the right shunt. Second, arterial arrhythmia, especially arterial fibrillation, but also arterial flutter or paroxysmal arterial tachycardia, increase in the frequency after the fourth decade, and can precipitate right ventricular failure. Third, most symptomatic adults older than 40 have mild to moderate pulmonary arterial hypertension in the presence of a resistance large left to the right shunt. Therefore, the aging right ventricle is bounded by both pressure and volume overload. Physical finding: hyperdynamic right ventricular impulse due to increased diastolic feeling and large stroke volume. S1 is typically split, and second component may be increased in the intensity, reflecting the forceful right ventricular contraction and delay closure of the tricuspid leaflet. S2 is often widely split and fixed because of the reduced respiratory variation due to delayed pulmonic valve closure, seen only if the pulmonic artery pressure is normal and pulmonary vascular resistance is low. The characteristic abnormality is found in almost all patients with the large left to the right shunt. Blood flow across ASD does not cause the murmur at the site of the shunt because no substantial pressure gradient exists between the arteria. However, ASD with the moderate to the large left to the right shunt result in the increased right ventricular stroke volume across the pulmonary outflow tract, creating crescendo-decrescendo systolic ejection murmur. The murmur is heard in the second intercostal space at the upper left sternal border. Patients with the large left to the right shunt often have rumbling mid-diastolic murmur at the lower left sternal border because increasing the flow across the tricuspid valve. This radiography. Cardiomegaly because dilatation of the right atria and the right ventricular chamber. Pulmonary artery is prominent and pulmonary vascular marking are increasing in the lung field. Left atrial enlargement is rare, only if the clinical significant mitral regurgitation. Proximal dilatation of the superior vena cava can be seen in the venous sinus defect. This radiography showed the cardiomegaly. Echocardiography. Type of ESD including evaluation of the right atrium, right ventricle, and pulmonary arteries, as well as other associated abnormality detection. Doppler echocardiography may be helpful in demonstration flow across the atrial septum. It's typically showed the biphasic systolic and diastolic pattern, with the small right to the left shunt at the beginning of systole. TEE is also useful in the guiding device placement during catheter ASD occlusion procedure and in the providing immediate intraoperative assurance that defect closure is accomplished. Continuous wave Doppler echocardiography is valuable for estimate the right ventricular and pulmonary artery when there is no associated right ventricular outflow tract obstruction and systolic pressure when tricuspid regurgitation jet is present. Contrast echocardiography can provide additional confirmation. Right to left shunt can be detected by visualizing the microcavitation bubbles in the left atrial and the left ventricle. A left to the right shunt can be detected as a negative contract washout affecting the right atrial. Cardiac catheterization. With uncomplicated ESD in children, routine cardiac catheterization for the diagnosis is unnecessary. Cardiac catheterization may be useful if the clinical data are inconsistent, if the clinical significant pulmonary arterial hypertension is suspect, or if concurrent coronary artery disease must be assessed in the patient older than 40. Catheterization is also viable alternative for intervention for secondum ASD. The diagnosis of ASD may be confirmed by directly passing catheter through the defected. A serial oxygen saturation measurement can be used to estimate magnitude of the shunt. In young patients, right heart pressure are often normal despite a large shunt. If high oxygen saturation is present in the superior vena cava, or if the catheter enters the pulmonary vein directly from the right atrium, sinus venous type is likely. Indicated for intervention and surgery. Elective closure ASD is generally recommended when the Qbqs is 1.51 or greater, ideally performed at the age 2 to 5 years before exercise capacity change, while the chest wall compliance is optimal and before the school age. An echo diagnosis for significant defect with the right ventricular volume overload is common and sufficient indication to close ASD. Contraindication. Irreversible pulmonary hypertension is the only contraindication to ASD closure. Irreversible pulmonary hypertension is characterized by pulmonary vascular resistance 8 to 12, with the QB and QS less than 1.5 and 1 despite vasodilator challenge. Moderate pulmonary hypertension with the reactive component is not contraindication to ASD closure, though the pulmonary hypertension may be progressed in this patient regardless of the closure. Generally, the PVR must fall below 7 with the vasodilator therapy. At the cardiac catheterization for ASD closure, risk to be less than prohibitive. Percutaneous transcatheter closure. The devices are placed through the femoral venous approach and deployed like an umbrella to seal the septal defect. This device works the best for central located secondum defect. Defect unsuitable for the device closure include those are having failed to attempt the device closure, common in the common arteria, or those without sufficient septal rim less than 5 mm to engage the device, and the sinus venous defect for which the device closure would threaten obstruction of the pulmonary vein and IVC and SVC. Ostium primum can be prohibitive for the device closure, as the device can interfere with the tricuspid valve, mitral valve, and coronary sinus. Anticoagulant with the antiplatelet, aspirin, and clopidogrel is indicated for 6 months after placement of the device. Complication of the device closure. The report overall complication rate followed catheter deployed ASD closure device is about 8%, including among the cardiac complication are the device malposition or dislocation, early or late embolization, arrhythmia, pericardial effusion, left to the right arterial thrombus, atrial or ventricular perforation, mitral or tricuspid regurgitation, or to arterial fistula, sudden death. Mitral or tricuspid regurgitation can result from the device interruption with chordae or chordae rupture, or leaflet perforation by the device or by delivery system. Reported non-cardiac complications include iliac vein dissection, retroperitoneum or groin hematoma, and leg ischemia. Minimal invasive approach. In the most cases, the size of incision is simply decreased with the different approach to cardiopulmonary bypass. The goal is to improve the better cosmetic result because this approach are not associated with the decreased morbidity or mortality. Risk phrenic nerve palsy, lung herniation, and breast or chest muscle deformity. Surgical closure. In the sinus venous type, ASD must be patched in such a way as to ensure that anomalous pulmonary venous drainage is diverting into the left atrial. In an osteoprimum defect, the patch must be attached to the septum at the juncture of the mitral and tricuspid valve. Mitral valve replacement is rarely, including closure of the cleft mitral leaflet and possible annuloplasty, may be necessary to correct or prevent mitral insufficiency. Complication of the surgery: early or late patch dehiscence, thromboembolism, and arrhythmia such as heart block, sinus node dysfunction, and atrial fibrillation or flutter. In ASD closure with pulmonary hypertension, systemic venous hypertension, right ventricular failure, and low cardiac output can result acutely. Necessity to return to cardiopulmonary bypass to fenestrate the closure. Early sinus node dysfunction occur in 9% of the patient undergoing repair of superior sinus venous defect. Prognosis after surgical closure. Prior to the ASD closure, above than 60% of the patient older than 40 are the class 3 and 4, whereas after the ASD closure, more than 80% are class 1 and 2. Patients older than 60 years show functional class improvement, immediate and late reduction in the pulmonary artery pressure, and improve 5 and 10 years survival after ASD closure. By comparison to the medical management. This data support the strategy of ASD closure regardless of the age for the symptomatic patient. Through some controversies remaining over the closure of asymptomatic ASD after the age 40, as a functioning classic deterioration and arrhythmia has been observed in this group after the ASD. Thank you everyone for listening.
Thank you, Muhammad.
يعطيك العافية. شكرا لك.
So any question or comment for Muhammad? So we'll have 10 minutes break and we'll start the second lecture after that. محمد.
ايوه دحين بدأت اسمع.
Yes.
Yes, Mohammed. Yeah, you can start. I would like first to welcome Dr. Mohammed Shahata for joining us to this session. Thank you, Dr. Mohammed, for your time.
Thank you for the invitation. Thank you.
Okay, my voice is clear.
Yes.
Okay. Me also would like to thank and welcome Dr. Shahata for joining us and supervising my presentation. Inshallah, today I'm going to go through the partial anomalous pulmonary venous connection, which is closely related to the previous talk, the atrial septal defect, and sharing a lot of similarity in terms of pathophysiology and presentation. So, as an introduction, it usually occurs when partial anomalous pulmonary venous connection. It occurs when one or more than one, but not all, the four pulmonary veins retaining to the right atrial side or to the right side of the heart rather than to the left atrium. And it's been estimated to be with an incidence of around 0.4 to 0.7%, and most of these reports coming from the autopsy series. Usually it presents as an isolated structural abnormality. However, it commonly occurs in association with other cardiac abnormalities, most commonly the atrial septal defect, and it's almost occurs in around 10% of patients with an atrial septal defect. Partial anomalous pulmonary venous connection from the right side is considered twice as common as those of the left lung, and the most common form of partial anomalous is the one in which the right upper pulmonary vein connects to the right atrium, or the SVC. Embryologically, the development of the pulmonary vein starts with the development of the lungs when the lung buds evaginate from the foregut, and there is a mesh of vascular plexus around it, which is the splanchnic plexus. With the differentiation and progression of the development of the lung, the splanchnic plexus forming a pulmonary vascular bed. This vascular bed eventually will drain the splanchnic plexus and usually connected with the umbilical line and the cardinal system. And with further development, the intraparenchymal pulmonary veins connect to the left atrium through a common pulmonary vein. The common pulmonary vein, usually identified as an evagination of the pulmonary buds from the atrial wall, posterior atrial wall. And usually it's entering, this communicates with the pulmonary vascular bed entering through the sinoatrial portion of the heart. And the site of the entry, usually to the left of the developing septum primum, cephalid to the junction of the left and the right horn of the sinus venosus. When the direct connection of to the heart is established, the communication of the pulmonary vascular bed to the splanchnic plexus, the umbilical line, and the cardinal veins usually obliterated. And with the process of differential growth, eventually the common pulmonary vein will end up with four opening into the posterior wall of the left atrium. And this diagram showing the stages of development for such a structure, initially with the mesh of vasculature around the pud of the lungs, communicating with the cardinal and the umbilical line veins. Then it will communicate with the common pulmonary vein. Then the obliteration of those communication with other splanchnic vein will obliterate it. Eventually, a four opening of normal pulmonary vein opening at the left atrium will result. Anatomical variation of partial anomalous. We can classify anomalous pulmonary venous disease as either an issue of connection or issue of drainage. Partial anomalous pulmonary venous connection occurs when a systemic vein results in mixing of the blood from the pulmonary circulation with the systemic vein before returning to the right side of the heart, meaning it's either connecting in the SVC or the anomalous vein before entering the right side of the heart. And it's in most cases, a secondum atrial septal defect is usually present. Such a pathology, including the left upper pulmonary vein connecting to the left anomalous vein, which is considered one of the most common. Other variants like a small segment of the right upper loop connecting directly to the SVC above the azygos vein, or other less common forms when the pulmonary vein connecting to the coronary sinus, azygos vein, or to the inferior vena cava. And another entity of disease, which is Scimitar Syndrome, we'll speak about it later. The second category, which is anomalous venous drainage. In this category, the pulmonary vein are connected normally to the left side of the heart, but due to other intracardiac defect, it will end up with the same physiological derangement, because the oxygenated blood from the that vein will enter to the right side, either solely or in concomitant with or a mix. It will be like overriding both atrium, draining to the right and the left atrium. And such a pathology, including sinus venosus defects, or in some situation in which the septum primer is malpositioned or left deviated to the left side of the atrial and at the atrial level. And the malposition of the septum primum, the anomalous drainage of one or more normally connected pulmonary vein results from a leftward malposition of the septum primum, and usually associated with a complex congenital anomalies such as hypoplastic left heart or heterotaxis syndrome with polysplenia. This diagram depicting different forms of partial anomalous venous connection. In this one, you can see the left upper pulmonary vein connecting to the SVC, and this one, the right upper pulmonary vein. Here, the left and upper and lower pulmonary vein connecting to the coronary sinus, and this is the common or a rare pathology, but well-identified entity of disease scimitar, in which the right side lung completely drained with the scimitar vein to the inferior vena cava. This is another diagram showing similar images of the previous one. We can also classify the partial anomalous venous connection as either associated with ASD, which is the most common form, constituting around 80 to 90% of cases, and it's usually a sinus venosus type. Usually the right upper or middle pulmonary vein is involved in such a pathology, or partial anomalous pulmonary venous connection with an intact atrial septum, meaning isolated pulmonary venous connection. And this anomalous drainage of the right upper pulmonary vein into the superior vena cava is one of the commonest form. Other is like when the left lung is drained to the anomalous vein. A third type was the partial anomalous pulmonary venous connection associated with other congenital complex congenital cardiac disease or the Scimitar Syndrome. The pathophysiology is mainly related to the left to right shunt, similar to that of the atrial septal defect. So the recirculated blood, oxygenated blood coming from the pulmonary vein, going back again to the right side and through the lung, will increase the flow through the right side, and this will lead to the developing pathology or signs and symptoms. And what can determine the manifestation or presentation is the amount of shunting, or what's called the Qbqs ratio. So the magnitude of shunting is dependent on different factors, and those factors which can determine the ratio or the amount of shunting, including, most importantly, the number and the size of the anomalous pulmonary vein. So, for example, if a patient is having only single pulmonary vein, most likely patient will be asymptomatic and there will be less hemodynamical derangement. Other factors including the pulmonary segment or the loops of the lung from which the anomalous vein is or was originated. And as it's known, the blood flow to the different segments of the lung is not similar, with the middle or lower loops having more blood going to more than the upper loop. So if the anomalous vein originating from those segments, the amount of shunting will be much more than the other segment. Third factor that determines the shunt ratio is the relative resistance of the normal and abnormal pulmonary veins, in addition to the compliance of the respective receiving chambers. Other factors that play a role as well is the presence of an ASD or any other intracardiac defect. Also will play a role in the amount of the left-right shunt and the presentation of the patient. So eventually, excessive pulmonary venous return to the right side of the heart will lead to right atrial and ventricular dilation, and this will lead to consequences of arrhythmia, right-sided failure, and development of pulmonary hypertension. The manifestation, usually the signs and symptoms and severity of signs and symptoms is related to the degree of shunting, as we mentioned before, and the presence of other cardiac defects. So patients with atrial septal defect and pulmonary partial anomalous, clinical findings are similar with the patient with ASD, and usually correspond to the shunt from both ASD and the partial anomalous vein. If the patient has a small degree of shunt, usually they will be asymptomatic, and they will be identified incidentally by a murmur detection during examination, routine examination. But if patient having more shunting with moderate to large amount of shunt, even if they were asymptomatic in the childhood, when they grow and age, the compliance of the left side of the heart will decrease and the shunt will increase, and the symptom will start to appear. Usually these symptoms will include dyspnea and fatigue, and may also progress to heart failure, depending on the amount of shunting. If the patient is symptomatic, usually they will present with dyspnea on exertion, recurrent pneumonia, and heart failure. For patients with isolated partial anomalous venous connection, hemodynamic abnormality generally do not develop unless a very sizable amount of shunting is present. And if it's involving multiple pulmonary veins, signs and symptoms dependent on the degree of shunting. So patient with an uncomplicated ASD, or in case of partial symptoms, will be similar to those as with patient with ASD or uncomplicated ASD. Physical finding and examination, usually related to the concomitant ASD, including the pericardial bulge due to atrial and ventricular enlargement, fixed splitting second heart sound, and it's usually seen with the ASD rather than the partial anomalous. And as ASD is a common finding, this finding in examination might be present. Systolic ejection murmur over the pulmonary area due to the physiological pulmonary valve stenosis due to the larger volume of flow due to shunting, as well as the low beta diastolic rumble over the left lower sternal or the tricuspid valve area due to also the physiological tricuspid stenosis. Investigation and diagnostic modalities. The routine investigations such as chest radiograph and electrocardiogram are not diagnostic, but may have some suggestive findings, such as in X-ray, patient might have evidence of cardiomegaly and increased pulmonary vascular marking. And in Scimitar Syndrome, of course, a scimitar vein might present as a characteristic finding in X-ray. We'll speak about it. ECG, usually in patients with partial anomalous, is normal, but might show evidence of right heart enlargement or right ventricular hypertrophy. Echocardiography is the most frequently used technique for diagnosing of partial anomalous pulmonary venous connection. And transesophageal is more sensitive than transthoracic. The finding in echocardiography that might suggest, or if we find it, we should consider the possibility of partial anomalous, including unexpected right atrial or ventricular enlargement, especially if there is no other explanation, or if there is less than 4 pulmonary veins connecting to the left atrium, or if we find a large and dilated SVC, anomalous vein, or IVC without other explanation. In such situation, we should consider the possibility of the patient having partial anomalous vein. Magnetic resonance imaging usually is considered when equivocal imaging or the quality of the echocardiography is not that good. So MRI can provide additional information. It can quantify the heart chamber volumes, the ventricular mass, the blood flow through the great vessels. And different techniques are used in the diagnosing of partial anomalous, including the MRA, using the gadolinium contrast and provide enhanced visualization of the pulmonary vasculature, including the anomalous vein. And the second technique, which is the phase contrast velocity mapping, and it's helpful in quantifying the Qbqs ratio. And it's a technique to measure the blood flow non-invasively. And this is a different image of a patient with a Scimitar Syndrome. This is an MRA showing the abnormal right-sided pulmonary vein connecting with a Scimitar vein to the IVC. CT or cardiac CT has several advantages to other diagnostic modalities. It is providing detailed anatomic information such as MRI, and it's more sensitive than echo, and it's not limited by acoustic windows or narrow acoustic windows such as echo. And in addition to that, it has a superiority over the MRI, as it's readily available and it can be performed in a shorter period of time. So if you have a child, you don't have to sedate him or anesthetize him. But of course, there is a risk of radiation and contrast use. Cardiac catheterization, although it's a modality that's been used for establishing the different diagnosis of partial anomalous, its role being decreasing with the advancement in other modalities such as CT and MRI. But it's used generally limited to patients undergoing therapeutic intervention, especially in case of Scimitar, to include the anomalous connection, the arterial-pulmonary connection. And it can provide additional hemodynamic information, namely pulmonary vascular resistance, cardiac output, and ventricular pressure. The management of patients with partial anomalous. Asymptomatic patients with small shunting usually don't require intervention, and their life expectancy without any intervention appears to be normal. But for symptomatic patients and those with clinically significant left-to-right shunt, surgery is the definitive treatment. And usually surgical intervention is indicated in cases of hemodynamically significant left-to-right shunt, meaning Qbqs ratio of 1.5 or more than 1.5 to 2 to 1, and often manifested as a right ventricular volume overload. In case of recurrent pulmonary infection, especially with in patients with Scimitar Syndrome and pulmonary sequestration, or during surgical repair of other major cardiac lesion. The surgical technique for repairing such anomalies, as we said, there are different types of partial anomalies, and most commonly associated with sinus venosus. So in case of associated sinus venosus, ASD, the general approach is through false sternotomy. This will give better exposure for proper inspection of the SVC to identify the partial anomalous vein. And the dissection of the superior vena cava before bypass may facilitate the recognition of the anomalous vein from the azygous vein by the color of the vein. The cannulation strategy, usually placing the SVC cannula remote from the ASD, and a regular straight cannula can be inserted through the right atrial to the IVC. If the plan was to go for Warden procedure, and we're going to speak about it in the coming next slide, then a right angle plastic venous cannula might be placed in the left innominate vein, or can be placed very high in the SVC to facilitate the procedure without interruption. Sorry. For cardiopulmonary bypass and cardioplegia, usually using mild hypothermia with cooling to 30-32 Celsius, and standard cardioplegic arrest is utilized. This is the usual technique for sinus venosus ASD if it's either lying low, and if the anomalous vein lying low in the SVC, or in the lying in the left atrium but draining to the right side, then an incision made from the atrial appendage, right atrial appendage toward the SVC, and with a retractor above the superior part to inspect the opening of the anomalous pulmonary vein. Then a pericardial patch is placed with a suture started in the between the orifice of the anomalous vein and the SVC, then continue to cover the atrial septal defect. By this, you puffle the anomalous vein to the left atrium and close the atrial septal defect at the same time. And this is a diagram to show the end result. This is the pericardial patch, and this is the pathway of the anomalous vein to the left atrium, and restoring a normal pathway to the right side with both the anomalous vein going to the left side, the atrial septal defect is being closed, and normal flow to the right side of the SVC without narrowing or stenosis of the SVC. In case, as we said, if the patient is having a very high connection of the pulmonary vein to the SVC, then a Warden procedure is the best to go for. And during this procedure, these two images are explaining the same procedure. What you're going to do, we're going to resect the SVC just above the insertion point of the anomalous pulmonary vein, and the cardiac end of that SVC is covered with pericardial patch to prevent stenosis of the pulmonary vein. Then an incision through the atrium is made, and a pericardial patch is placed to baffle that pulmonary vein to the left atrium and closing the atrial septal defect. Then the distal part of the SVC, the resected part of the SVC, is anastomosed to the right atrial appendage. And when incising the right atrial appendage, it's important to remove the trabeculation to prevent any stenosis or obstruction to the flow through the SVC. And this is the end result with restoring the flow of the SVC to the right atrial appendage, the atriotomy incision closed, and the pulmonary vein going through the pathway to the left atrium. In case of isolated left upper pulmonary vein connecting with the ascending left-sided vertical vein, the vertical vein is divided just below its junction with the left innominate vein, and then anastomosed to the base of the left atrial appendage. And it's important to take care not to cause any torsion in the anomalous vein. And this is usually not the case because it has a good length and will give flexibility in mobilizing that vein. in case if there is no associated atrial defect. So there is a right-sided pulmonary vein, but there is no atrial defect, then we're going to create an atrial defect. And the way to create it is usually by making an incision in the base of the fossa ovalis. And then, as the same previous technique, we will use an autologous precardial patch suture around the orifice of the anomalous vein and the surgically created secundum ASD to buffer the flow to the left atrium. With regard to the Scimitar Syndrome, it is a variant of partial anomalous venous connection, pulmonary venous connection, in which part or even the entire right lung is drained by the right pulmonary vein connected to the IVC. Usually the affected lung and its associated airway are hypoplastic or having unusual bronchial or vascular distribution. Sequestration and orthopulmonary collateral may also involve in the affected lung. And up to 70% of patients with Scimitar syndrome have other associated cardiac defects, and most importantly, or commonly, is the ASD. Other cardiac defects seen with such a pathology, including hypoplasia of the left heart or of the aorta. Signs and symptoms similar to previous, as we said, mainly dependent on the amount of shunting, the degree of the pulmonary hypertension, as well as the parenchymal disease and associated cardiac lesion. Usually, patient with Scimitar syndrome has two distinct clinical presentation or profile. In the adult form, patients usually mildly symptomatic with exertional dyspnea and recurrent respiratory infection, while in infantile form, patient has more severe symptoms and present in the first few months of life with failure to thrive, cyanosis, respiratory distress, as well as congestive heart failure, and usually related with associated with severe pulmonary hypertension. To diagnose Scimitar syndrome, chest radiograph or chest X-ray findings include the characteristic scimitar appearance of the anomalous vein, and this is the characteristic picture of a scimitar vein collecting the venous drainage from the right lung, directly going downward to the diaphragm to be inserted to the IVC, and this is an MRA showing the same pathology of the same patient. Other finding in X-ray, including small right lung with displacement of the right of the heart to the right side. Echo usually is diagnostic and can identify intracardiac lesion associated and visualize the location of the anomalous vein. Cardiac catheterization in such patient can be diagnostic and therapeutic as well. It can diagnose and identify the anomalous systemic artery or the orthopulmonary connection from the descending aorta, and if it's found, usually it's either coiled or embolized during catheterization as a therapeutic option in such patient. This is an angiogram of a patient with Scimitar syndrome showing a normal connection of the left lung while, with a drainage of the right lung through the Scimitar vein. Management of such a patient, usually most important, systemic arterial supply to the lung, either to be divided surgically or ideally to be closed during catheterization, either with embolization or device coil closure. Options for repair of such pathology as being reported by Kirkland and his colleagues, either to be directly anastomosed to the left atrium or an intracardiac patch to buffer the flow to the left atrium can be utilized. In case patient having inflammatory parenchymal changes, which is extensive, or there is persistent hemoptysis, a marked hypoplasia of the right lung, pulmonary resection or pneumonectomy might be considered. So some details about surgical technique. It's generally helpful to utilize deep hypothermia or deep hypothermic circuit arrest for placement of the autologous patch. And it's advisable to use a straight cannula during cooling phase rather than directly cannulating the IVC, and that's to avoid any narrowing of the pulmonary vein during purse-stringing or purse-string the orifice. When deep hypothermia achieved, the cross clamp is applied and cardioplegia is infused, then the arrest begun. Once arrest begun, the caval cannula is removed, and the autologous pericardial patch is sutured around the orifice of the scimitar vein, and it's important to take care not to purse-string that orifice. And it's buckled around the orifice of the inferior sinus venosus ASD. In cases when the scimitar vein enters the IVC very low, then the option either to divide the vein and either reimplant directly to the left atrium with either end-to-side or using end-to-end, side-to-side or end-to-side anastomosis to the right atrium and buffle it. This image showing the technique for repairing a Scimitar syndrome, usual oblique incision of the right atrium, then with a retractor exposing the IVC opening and the to inspect for the abnormal venous opening of the scimitar vein. And here we can see the abnormal orthopulmonary connection, which should be either closed during catheterization, or if it's not, should be divided, ligated and divided surgically. Then a patch is sutured initially around the orifice of the scimitar vein, and then it's buffled through the inferior sinus venosus ASD to directly flow to the right, to the left side of the heart. In some surgeon may, when closing the lower part of the atriotomy incision, they might use a patch to enlarge the orifice of the IVC and prevent any narrowing or stenosis of that opening. And this is the end result with the patch closure of the lower part of the atriotomy. As I said, if the scimitar vein is inserted very low in the IVC, then either to ligate and resect and anastomose side to side to the left atrium, or resected and anastomose end to side to the right atrium, and with a patch you buffle it through the ASD to the left atrium. And this is it for my talk. Any question? These are my references. Thank you. Dr. Mohammed, any comment from your side?
Excellent talk, Mohammed. Very comprehensive. And I guess I really don't have any comments to say, but maybe if anybody has a question. One thing I would mention while people get their questions, if they have any, I find it quite common that people mention deep hypothermic arrest for exposure of, deep-seated structures, mostly pulmonary veins or anomalous pulmonary veins. يعني طبعا that's a traditional way of exposing things, is just to turn the pump off under deep hypothermia. It's quite often unnecessary to go to a complete circ arrest. Even say you have a tear in the IVC, or there's a Fontan operation with a very short IVC, and you need to remove the IVC cannula, you can still maintain blood flow to the body and go on low flow sucker bypass. And quite often that gives you the exposure you need. You don't have to go on complete circulatory arrest. And with the modern pumps and the vacuum assist, the perfusionist can cope with microbubbles that come even if you decide to keep the IVC cannula deep and remove the snare just to get better exposure. Quite often if there is a good return, they can manage that, and you don't have to remove the cannula. But even if you had to remove it, you don't have to go on circuit arrest. You can go on one cannula in the SVC with an additional sucker or 2 suckers inside the heart. Usually that gives you the exposure needed. It's quite uncommon nowadays to go on complete circuit arrest for these things. But it's still an option. It's not wrong to mention it. Some people might prefer it. I guess it's less of a hassle, but you have to be thoughtful about the effects on the brain and other organs. But yeah, that was the only comment I wanted to make.
One point, Dr. Shahada, I have read one novel technique being published by Dr. Hani Najm for repairing a distant partial anomalous pulmonary vein, in which he used the pericardial roll. Actually, I couldn't comprehend the full concept, and that's why I did not include it in my presentation. If you can give us an idea about it.
For the scimitar, or for what kind of problem?
He was mentioning it for scimitar or for distally inserted partial anomalous vein. If it's inserted very low in the IVC or very away to be just directly anastomosed or baffled to the left side of the heart.
Yeah, to be honest, I'm not familiar with that report, so I'm not sure what he describes, but Hani is quite a pioneer in our field, and I'll be interested to look it up and see what he's written about it. But the bottom line of these repairs is that you want to baffle into the left atrium with the shortest pathway and an unobstructed pathway. And whatever possible way you need to achieve that, direct connection, an interposition pericardium or an intracardiac baffle, then I guess preference also plays a factor here. These are not very common cases, so I'm sure each of the surgeons do it a bit differently. But to comment on that report specifically, I have to look it up. I'm really not familiar with it.
Thank you, Doctor.
Thank you, Mohammed and Dr. Shahata, for your comments. So any question for Mohammed?
I guess it's very clear.
Yeah, I guess so. All right, so we'll conclude the session for today. Thank you, everyone. Again, thank you, Dr. Shahata. We'll see you, inshallah, again.
Thank you. Have a nice
Dr.
weekend. Yes, anytime.
Thank you.
Inshallah. Assalamu alaikum.
Thank you, Dr. Babgi and Dr. Mutlaq.